Hey, Dr. Dan Cooper here. I wanted to give you a little bit of a primer on physical rehabilitation. So as chiropractors, we have a lot of tools at our disposal, and really it's a matter of accessing those tools and deciding which ones you're going to use and which ones you aren't. In regards to physical rehabilitation, we have three basic reasons for rehab to be needed. We have acute injuries that occur, we have chronic motor patterns that are aberrant, and so they will then result in overuse injuries, and we have postural aberrations as well, which technically are motor pattern alterations also. So how do you figure out what you're going to do with a person? Is it, I have a problem squatting, I have pain when I go upstairs, or whatever the thing is, and so that equals this prescription? It doesn't. You have to find out what's actually going on with the person in a pretty good degree of specificity. So in the history, it's going to tell you, and the observation, the history and the observation are going to tell you which one of those three reasons for rehab are we looking at. Does this person have an acute injury? That'll come from the history. Do they have postural aberrations? You can see that just by looking at them. And do they have poor movement patterns? That might take a little bit more investigation. But then you need to zero in. So you need to zero in on the precise problems that person is presenting with. So how do we do that? We evaluate people's physical problems with functional movement screens. We have orthopedic testing that we can do. You can evaluate firing patterns. And that's something you can do with the selective functional movement assessment from Gray Cook. You can do, MAT has a muscle activation technique. They have an evaluation as well. There's a number of them out there, but you just choose which one you want to do and do it. And then you can palpate. So palpating the actual structures, once you have an idea of which ones you think are involved, you palpate them and see what they feel like. Are they eliciting pain? Are they eliciting the original symptom that they're complaining about? Because sometimes it's not pain. It's some other sensation that they know is not normal. And then we fix it, right? And so there's what do you then do after you figure out what is specifically going on with the person. And in order to do that, we have a few tools at our disposal as well, and a few different things that can go wrong with a person that we would need to fix. So we have tissue length discrepancies. Myofascial release, easy way to go. So myofascial release can be done in a number of ways. You can do it through tools, the IASTM. You can do manual therapies as well. For lengths, so if it's not just adhesions and dense tissues, it's also the lengths are off, then you can do PNF, or FRC has, functional range conditioning has a version of PNF that they do. So choose some sort of stretching modality to bring those lengths back to an equality across whatever joint we're referring to. There can be joint restrictions. What do we do with the joint restrictions? So we adjust those joints to restore the full natural range of motion that should be available to that joint. Then it comes to exercise prescription. This is the stuff you think of when you think of rehab. And exercise prescription is done in a way. It's done in a way that is isolated to the degree that it needs to be. Because sometimes, say you have an acute injury and tissues are damaged, it's not just a pain syndrome that's occurred from poor motor patterning and tissue damage hasn't really occurred. It's more of a neurological pain. Say there's actual tissue damage, you need to rehabilitate that tissue before you can really stress it. So that could be passive therapies, it could be passive movement, it could be very light active movement, whatever the case may be for that, whatever that patient's needs are. And then you progress. That's kind of the deal. You isolate to then integrate into fuller movement patterns. And as you're progressing your rehab protocol, whatever you decide is your protocol, there is a progression. It progresses in intensity and complexity to whatever level that person wants to be at, or you've deemed is where you want to get them to. That's the level that you need to progress them to. And progression isn't always just like the weight move or that load that's being moved. Sometimes it is, but also it's complexity of motor patterns. So if you had to retrain somebody's breathing pattern, and you do that in a stationary fashion, whether you're just practicing the breathing patterns, and then you add in limb movements while they're practicing the breathing pattern. So you're adding in another motor pattern to this fuller motor pattern. So there's the breathing pattern, you add in some other movements, maybe it's walking and breathing, maybe it's throwing, whatever the other movement is that relates to this person. But the point is that in addition to increasing a load, you increase the complexity of the motor patterning to end up in whatever you want this person to achieve. I just wanted to give you a little primer on what is rehab or physical rehabilitation and what sorts of things should we be looking at in the evaluation and then the treatment portion of physical rehabilitation. I hope that helps.